Patient falls are the most frequently reported adverse event in the adult inpatient setting, and the results are costly both to the hospital and to the patient. Falls and injuries from falls can exact a toll on the caregiver as well. Preventing patient falls continues to be a challenge for all of us, and the Partnership for Patients initiative has made it a focus, fueling a determined drive to reduce patient falls, targeting aggressive improvement goals. Today we're featuring two organizations who've used VHA's Rapid Adoption Network methodology to empower frontline staff to examine specific problem areas leading to falls and uncover hidden barriers to fall reduction, and finally implement proven strategies that have already begun to work. I'm Reid, Vice President and Chief Nursing Officer at VHA and your moderator for today's program. We're broadcasting live from the VHA TV studio in Irving, Texas, and we can't wait to get started. Stay tuned.
You're watching VHA TV, the award-winning satellite network of VHA. This program is confidential. Duplication of this program without permission of VHA is prohibited, except for use by participating healthcare organizations.
The Partnership for Patients initiative has identified areas of focus that, when addressed, will help us reduce preventable readmissions and hospital-acquired conditions from across the country. Today we're going to focus on reducing falls and associated injuries by engaging the front line and finding those hidden barriers which prevent achieving performance excellence. Reducing falls has been a long-term challenge for healthcare, but we're finding that hospitals and VHA's Hospital Engagement Network who are working on reducing falls are achieving their goals in record time. We're seeing new approaches that generate real impact, like the implementation of nursing bundles and the use of innovative technologies. You'll hear today from teams in our Hospital Engagement Network who'll tell us what they're doing to address this ongoing challenge. Here are our learning objectives. After viewing today's program, you'll be able to describe the hidden issues that exist in the hospital setting which contribute to falls, and discuss strategies to reduce falls and decrease patient injuries from falls. If you've downloaded the handout, you'll find pages where you can take notes and resources you can use to dig deeper into the strategies we're talking about today. Those references can be found on page 9. Now let's meet our leading performers. We have an outstanding panel from two organizations who've successfully implemented fall reduction strategies. First, you'll meet the Axela Health team, and then we'll talk with the team at Reid Hospital and Healthcare Services. Joining us from Axela Health is Kravec. Welcome, Katie. Tell us a little bit about yourself.
I am a registered nurse, and I've been in practice for approximately 26 years. I am employed by Axela Health for the last 17 years, and I am currently the manager of the inpatient rehab unit and also the acute care neuro unit at Axela Health.
Well, welcome. Also joining us is Doug Densen, who's Chief Nursing Officer there. Doug, welcome, and tell us a little bit about your background.
Thank you, Lily. It's great to be here. I am a registered nurse, and I've been at Axela Health for the last 3 years, serving in the role of Vice President of Patient Care Services. Axela Health is a 3-hospital system and includes many outpatient facilities located in Greensburg, Pennsylvania. I have been involved with the Falls team for that length of time, facilitating the discussion that has taken place, as well as serving as the administrative sponsor.
Well, we're so glad you could adjust your schedules to be here with us. Following our discussion with Axela Health, you'll meet the Reid team a little later and learn about their successes as well. But before we get started, Here's how you can join the discussion or ask us questions. Use the internet on the webcast page, select Ask a Question, type the question, and click Submit. Send us an email at vhatvlive@vha.com or call us at 800-565-8107 and be sure to press star 1 to join the conference. Now, Doug, let's get started with you and the team at Excela. How did this whole topic of falls get such a high level of attention?
Well, Lee, we looked at our fall rate and compared it with the national average and learned that we were higher than the national average. We would present our issues to the board, and they were obviously concerned, as were we. We then took a look back 3 years, and we did not discover any movement, plus or minus, from the program we had in place. So we thought that Partnership for Patients was an excellent opportunity for us to focus on falls. And that is how we began our journey.
Well, I thank you for your honesty there. A lot of the things that you'd been doing weren't working, so you had to do something different. So, okay, falls got a lot of attention at the board level. How did you actually begin?
Well, we began by doing a review of the literature. We connected with our colleagues and tried to discover some of the quality improvement initiatives that were being undertaken at other organizations. We sought expert opinion. And then we happened upon an article that had been published in the Journal of Nursing Administration by the local university.
And what was so important about the article? What learning did you gain from it that really served as the platform for your whole program?
I think the aha moment was when we learned that the program was based on the premise that every patient was a fall risk. And the particular focus then that we would take would be injury risk instead, and discovering ways to reduce injuries that were related to falls.
So let's be really clear here so everyone understands what we're talking about. Excela's approach is an assessment focus based on falls with injury, not falls risk. Is that correct?
Absolutely.
And one of the important components that you've implemented that I'm personally really excited about is the concept of the nursing bundle. Tell us more.
That's correct. Well, as I'm sure you know, the nursing bundle is comprised of interventions that, when performed all together, seem to have a greater positive effect than if taken individually. So there are approximately 3 of them. One is universal in nature, which would apply to all patients that were hospitalized. And the other 2 levels are dependent upon the injury risk that we assess.
Great. And Katie, in addition to the nursing bundles, what other strategies were implemented?
Well, we formed a multidisciplinary team to start out with. And what we did was compiled that team of nurses, technical partners, administrators, physicians, members from the risk management team, the quality team, and we developed a tool that allowed the nurse to assess the risk for injury that a patient may sustain if he or she had a fall. And what we did was we decided that we would do pilot units. So we have a 3-hospital system, and we did a pilot unit at each of our 3 campuses. And that nurse manager on the 3 campuses did an inventory of equipment, and we did some education of staff. And our premise to the staff, we needed to get their buy-in for, which was not assessing for risk for fall, but risk for injury. So that was a big issue to get education out to the staff and get their buy-in. And then we wanted to make sure that they understood they owned the process. They owned the pilot. They owned the feedback. They needed to get it to us and get it back to us quickly enough so that we could implement changes if necessary. So we wanted to know the good, the bad, the ugly.
So buy-in and ownership, so many of our hospitals are struggling with those 2 concepts. What other challenges did you encounter? Or were those the only ones?
No, no. One of the ones that I think was a big one was equipment. We did try to do some technology. You know, technology sometimes can be a nurse's best friend. And we did an assessment on each of the pilot units, and each of those nurse managers found out what she had and what she needed, and then we needed to have them order that equipment. So one of the units in particular ordered all of that equipment in a bulk. So say, for example, she needed 30 chair alarms. She ordered all of those chair alarms at one time. Whereas another unit ordered their supplies incrementally. So that when we started the pilot, what we found was the nursing staff on the unit that had their equipment were able to perform to the level we wanted them to, whereas the patient or the caregivers on the other units didn't have the tools to do their job. And it was a big learning moment for us.
That seems so simple, just having the right equipment at the right time at the right place, and assuming that the pilot units would all do it the same. That almost leads into some of the hidden challenges that are uncovered when you're trying to improve. What else did you find that was a hidden issue?
We found a couple, actually. One was the staff perception. We really needed to get into them the fact that we're measuring that fall risk, injury risk, instead of fall risk. That was a big deal.
Big deal.
And we used examples, and one of them I'll share with you. Say if you were admitting a patient that was 26 years old that has asthma. So you start an IV, you keep them in the hospital for a couple of days. We wanted our staff to understand that she was a fall injury risk, or a fall risk, and also if we look at a patient that we admitted that was, say, 85 years old, same diagnosis, but came in with a frailty, osteoporosis, and was on Coumadin. Now your 26-year-old patient had virtually no comorbidities other than their asthma. They could trip over their IV pole. There's still a fall risk. But the patient that has osteoporosis and has Coumadin on board is more of an injury risk because of the issues that could happen if she did fall. That was one big issue. And then the other issue we had was storage. We had a storage issue because, as you all know, we have limited storage on nursing units.
Everyone, that's right.
Everybody does. So we had to be creative, and some areas had some storage areas that they could organize and use for their equipment. Other areas had to be creative and maybe even look at having pieces of equipment in every single solitary room.
Really interesting. As a part of your hidden issue, though, you've also talked about you stopped doing some things, and it had to do with beds, right?
Surprisingly, we discontinued the use of low beds.
Really?
Yeah. I know that's a big surprise for a lot of people because the tendency is to go to a low bed. But what we found was that staff and patients were actually tripping over cords, tripping over the low surface, or getting hurt. So we eliminated the use of low beds, and it has not made a difference. The low beds did not make a difference for us. So we're saving money, and we're still providing a great level of care.
So you stopped using low beds. Doug, what about those cultural issues? You sit at the system level, seeing things across all three hospitals. Any hidden factors, gleanings there?
Well, Lily, each campus needed some individualized attention because it was difficult for other campuses to accept the work that had been performed on only one of them. So we had to talk that through, and we were successful in doing so.
That is so important to understand. The not invented here syndrome is real, and being able to accommodate that is so important. Tell us about some of the other tools and interventions that you've been able to use to be successful.
Well, fortunately, we recently implemented an electronic medical record, and the assessment and intervention tool that we had used on paper was now converted to an electronic format. So not only was it built into the daily work of the nurse was prompted to do an assessment. In addition, accessibility of equipment, as Katie had referred to, was also problematic. And so based on the feedback from the team, we did equip bedrooms with the equipment that was necessary so that staff would not have to look for it and would have it for their use when needed.
So give us an idea of exactly what equipment in each room.
Well, as an example of floor mats, we found a floor mat that actually folded in three and had a handle on it that could be hung on a hook on the back of the door, so it was always available. And then in the drawers we placed bed and chair alarms, since those were also critical to use when indicated.
So no hunting and gathering, and it really is every patient, every piece of equipment, every day.
Correct.
Oh, that's a nurse's dream, I think.
Absolutely.
You refer to the concept of universal interventions. You mentioned that during the nursing bundle discussion. Tell us a little bit more about that.
Well, I wanted to mention in particular that one of those interventions were the use of the patient encounter, the purposeful patient encounter, whereby clinicians were taught to follow a standard etiquette, if you will, when beginning that encounter with a patient. That would include things like, are you comfortable? May I start this procedure now? By teaching providers who entered the room to do that would help ensure patient safety. We did a study to determine how many encounters a patient would experience on average per hour, and learned that there were approximately 6 of them.
Oh my goodness, so 6 people in the patient room every hour.
That's correct.
And so moving to this purposeful encounter piece, isn't that just hourly rounding?
Well, it's different in that all providers that have that encounter with the patient are taught how to keep the patient safe, so it becomes a shared responsibility among them.
Even doctors?
Even doctors.
Oh, wow, that's
Even
great.
housekeepers.
Even housekeepers, okay. Katie, what are the specific approaches that you use for patients that are at risk for injury?
We have 2 levels. One is a level 1 lower risk for injury and a level 2 higher risk for injury. And each of those levels have mandatory interventions and then also optional or recommended interventions. We do universal interventions for all levels. At level 1, our required intervention is fall injury prevention kit, which consists of basically a baggie, a Ziploc bag, that has a fall risk band in it, has non-skid slippers, it has a patient education tool, which is actually a little tent card that the nurse is to take into the patient's room and then explain to the patient why we're putting you on fall precautions, what our responsibility is to you, and then what your responsibility is for us. And we use a teach-back methodology with the patient and with the family members that may be in the room or come in later. We also do supervised toileting, which is always a joy. And we also ask for an order for PT and OT functional assessment so that they can recommend a piece of equipment that maybe the patient may need, a walker or a quad cane, for example, in the room, so that we keep them safer.
So what's the optional list?
The optional list is kind of fun, actually. We use bed and chair alarms, personal alarms, lap belts with alarms that are self-release, lap buddies. One of my favorites, probably a lot of nurses' favorites, is something called a one-way glide.
What is that?
Whereas if, I think we've all had this instance where a patient starts to scoot down in the chair.
Oh, yes.
They start to scoot down and they're going out the door here, but this one-way glide keeps them from pushing forward in the chair, hopefully preventing a fall.
Oh, that is kind of fun. What are the interventions then for the patients at even higher risk? The level 2s, is that right?
Level 2. We use all of our universal precautions. We use also all of our level 1 precautions. And when we add level 2, we mandate a use of a bed and chair alarm. We also mandate the use of floor mats. And then optionally, which nursing has done this for many, many years, we're now putting just put an option for it, is to keep the patient close to the staff, where is close to the nurse's station or close to the hub of the activity on the unit. We also use, we do consider the use of sitters.
Sitters? That's really controversial, I know, across many of our hospitals that are trying to actually eliminate them to reduce costs. So do you use a lot of them?
We don't. We really do try to use as little sitter staff as possible. And what we found is that it's really not necessary to provide a sitter that is employed by the hospital, although we do have a job description for a sitter, because we can enlist other methods, maybe a family member. We'd like to bring our family members into our fall program with us, our fall prevention program, and maybe a husband that would like to stay with his wife, would like to calm her. That is a lot easier for a patient to absorb. It's a lot better than having a sitter that they don't know sitting at their bedside helping them to be safe.
Doug, orders aren't needed for these interventions. These are nurse-driven bundles?
They're nurse-driven bundles. That's correct.
Terrific. So now that we understand these 2 intervention levels, move quickly to the safety checklist concept that you implemented.
Well, back to what Katie had indicated initially, we put together a list of all equipment that would be necessary to execute the bundles fully, as well as the manufacturer and the cost, so that by making it accessible and easy to do, it would likely get done.
And by making the cost visible, caregivers really have a clear understanding of what's being implemented. So why did you create the checklist? Seems like we have a lot of checklists in healthcare. Why another one?
The checklist was really more of a reference tool so that the equipment that was necessary would become accessible to the staff.
And how did you use the Rapid Adoption Network methodology to find the hidden issues, to develop your lists and so forth? What is important for us to know about the methodology that really resonated with Axela Health team?
Most importantly was the engagement of the frontline staff. They would trial various interventions, they would bring back feedback, they would recommend changes, and as long as the changes were well grounded in the science or in the literature, we would implement them and then meet another week later to find out how effective they were.
So that was part of that ownership. You talked about what was different now than 3 years ago with everything else that you were trying. There was real staff engagement and ownership, right?
Correct.
So have you had any results yet?
We have.
You have?
We have. We have achieved a 30% reduction in fall injury in our organization.
Well, congratulations. That's fantastic, especially after you said for so long you kept doing the same thing and it wasn't getting you anywhere. 30% increase.
It's exciting.
And what are you going to have to do? You're going to have to keep going, right, to make sure it's sustained?
We'll have to keep going. We continue to go weekly. We don't want this to fall off our radar until we're confident that we have it right.
Well, you're obviously doing many things right, and the front line is doing many things right. Thanks for sharing some of those concepts with us. Before we introduce the Reid team, let's visit Axela Health and hear from others on their team about what they're doing. Take a look.
You feel incredibly horrible when your patient falls because you feel like you should have been there, you should have been able to prevent this from happening, because a lot of times it's devastating not only for the patient but their family. But really changing the focus of we want to keep them safe. We have a lot of Alzheimer's and dementia patients, and we know that the longer we keep them out of their environment, the longer or the increase that they're going to have events because they're not in their environment. And just them being confused, being outside of their environment, in addition to the medical condition that they're going through at that particular point, is going to increase their risk inevitably.
We saw that we were so much higher than the national average, and we realized we had a problem that we needed to address. We formed a falls committee. We have representatives from nursing administration, all levels of staffing, RNs, LPNs, nursing assistants. We looked at our data. We compared it with the national averages.
All patients are considered a fall risk. And so we look at the fall with injury, not just the fall risk, is what we look at when we're on this team.
Number one, we identified it at Axela Health as being an issue. Number two, our administration was on board saying whatever that you need in order to increase the awareness and to also decrease our numbers, we're willing to do. I think those were the first major two steps. The third step being doing a literature review. And then the fourth thing is really taking and engaging staff at the clinician level, those taking care of the patients, and all of those people that are involved in that patient's care, whether it be physical therapy, occupational therapy, escort, patient safety, the technical partner, the nurse, looking at that as an interdisciplinary look and not just as the nurse.
We do an assessment, and a comprehensive assessment on admission. We reassess daily, and we have established bundles based on our assessment of the patient's risk for serious injury.
We have eliminated the use of low beds across the health system, which in itself decreased our fall injury risk, which was something that I have to say I was a skeptic on, but we actually found that to be true and have seen a reduction in our fall injury risk.
The first thing we had to make sure is that the frontline staff was educated and that there was buy-in. If you don't have buy-in from the frontline staff, your program won't work. It's improved outcomes because we've actually have the data collected that show that we have reduced our falls with serious injuries by 30%. And we're very pleased with that. We think we're on the right path, and we would like to see even more improvement.
Congratulations to all of you at Axela Health. Real teamwork, real results. Now let's meet another VHA leading performer, Reid Hospital and Healthcare Services, located in Richmond, Indiana. Joining us from Reid is Sally Stoller. Welcome, Sally, and tell us a little bit about yourself.
Thank you, Lily. I'm Sally Stoller. I'm a registered nurse, and I'm the Director of Patient Safety and Quality at Reid Hospital and Healthcare Services. I've spent my entire 37-year nursing career at Reid, and my interest in falls starts certainly from the patient safety focus, but as a member of the risk management team, I also recognize the potential impact to our organization when a patient falls, particularly if there's an injury.
Thank you so much for being here. It's great to have you. Also joining us from Reid is Lisa Suttle. Lisa, welcome, and tell us a little bit about yourself.
Thank you, Lily. I'm the Director of Psychiatric Services at Reid Hospital, and I've been an RN for 22 years, 7 of those years at Reid Hospital. I'm chairperson for the hospital fall team, and my interest in this area is due to the cognitive component and how the patient is at a higher risk for falls because of that impairment.
What a great talent to have to bring to the team around the cognitive aspects of falls. Welcome.
Thank you.
Like Excela, you've been working on a number of initiatives. How in this process did you focus and start with falls?
Well, as you commented, like Excela, and I'm sure everybody in the audience out there, we were working on falls for a really long time. 3 years ago, we added a lean department at our hospital, and the director of that department, Carol Owen Clark, decided to use fall reduction as her black belt project. And so the very first Kaizen that we did, if you're familiar with lean terminology, the very first Kaizen at Reid Hospital was on falls reduction.
So when you did that, what did you find out? What were some of the first things you learned?
One of the basic premises of lean is that you have to be able to study your data. You use data to know where you need to make improvements. And what we discovered is that we were really lacking in accurate data or valuable data. Our incident reports were quite sketchy. You might get something that said, patient fell. But we didn't know, was it because they were getting up to go to the bathroom? Were they trying to get out of bed on their own? Did they trip over something? So that's where we really started our work.
Isn't that interesting? Because we do think intuitively that we've got plenty of data through our incident reports. So talk more specifically about what you're doing to prevent or reduce fall rates.
Okay. One of the things that came out of our Kaizen is that we have a fall response team. They respond whenever there is a fall, and part of their responsibility is the completion of a post-fall huddle form. We get the detailed information that was related to that fall, but probably the most important thing that the fall response team does is look for an opportunity, work with the people involved. How are we going to prevent a fall from happening with this patient in the future? And it was interesting when we went to our clinical design day for the Partnership for Patients initiative using VHA's RAN methodology, the Rapid Adoption Network. Many of those tools are very similar to what we use already in our lean management approach.
And it's so important that we show staff the alignment of these methodologies and why one supports the other, right? So,
Absolutely.
So as a part of this work, you've implemented the fall response team, the post-fall huddle, right? And so it just seems like everything is going hunky-dory. Did you face any challenges?
Oh, I'm not sure I would use the word hunky-dory to describe what's going on. But yes, it was, I think, probably the biggest challenge that we faced, and I even had to come to this conclusion myself, is that we have to get past the notion that, or the assumption that people are going to fall in the hospital. It's very important for us to realize that we can prevent this. We can reduce falls. And so again, with the work that we did at the clinical design day, Lisa and I came to the conclusion that we really needed to focus on the staff's understanding of the role that they play and understanding their accountability and making our patients safe.
So, you know, that really is a long-term bias in nursing when you think about it. I know I had it as a staff nurse. Patients are just going to fall. So when we think about other challenges, any enlightenment from your standpoint?
Yes, actually, I definitely agree with that. You know, people come with the mindset that falls are inevitable,
right,
that they're going to happen. Sometimes they come with the mindset, too, that we've done everything that we could do, and I'm sure all of you out there have said the same thing. I did everything I could do for this patient, and there's nothing else that I could do. It's about opening up. It's about thinking about out of the box and other things that could be done. most people, and I would say everybody, does not want anybody to fall. They don't want to be blamed. They don't want to be disciplined for a fall. And they know that there's a lot of attention that's placed on a fall. All of you know that. When a fall occurs, everybody's looking at it to see what's going on. So it can be embarrassing for that nurse. It can be a feeling of failure or guilt in many ways. So I think we just really uncovered that with people and trying to work through that and kind of decrease that fear and anxiety with everyone is what we're trying to do most.
So what were some more of those hidden issues that you uncovered, more of those human factors types of issues?
Absolutely, yes, I would say so.
Well, Lee, one of the things that really caught our attention, and it was one of those aha moments, was we found out that there are times when the unit directors were not even aware that a fall had occurred on their unit. So we needed to make sure that they were involved when we called that fall response team.
And so you added the unit director to the review process?
Yes, added the unit directors, but we also included the charge nurse in that group too. And as you all know, being a charge nurse, you're responsible for the unit, and at the same time may not always know everything that's going on. So when you're reviewing that fall too, you're becoming part of that link and what you can do to improve that process. We also looked at some other areas too. Our Zone 3 beds, we looked at where they were located at and if they needed to go to an area where falls were higher. And to just kind of describe our Zone 3 beds a little bit, they provide a greater sensitivity on the bed and alert a nurse when there is minimal movement by the patient. And it gives the nurse more time to get there. It gives the staff more time to get there before the patient is trying to get up or before a fall occurs.
Well, it really is a great story and an aha moment when you were telling the fact that they have a beautiful brand new facility at Reid, and the brand new beds went to the maternity unit, is that right?
Yes.
Which is actually where there's the lowest fall risk. So as a part of this process and uncovering some hidden factors, you move the newer beds to the units with patients with higher fall risk.
Yes.
Is that right? That's really a great story.
Yes.
Do you have standard interventions for patients with at fall risk?
Yes, we actually do, and there are several that we use. Just a couple to talk about. Toileting. When we're toileting with a patient, we want to make sure that we stay with the patient at all times, and that's very important, but also it brings the concern from the family and from the patient about privacy. And as you all know, when you're working with those patients, they don't like for us to stand right over them, especially during a time, you know, when it's very private for them. So it is about privacy and it's about safety, but it's also about education and making sure that we let the patient know why we need to observe them. And sometimes we forget just that little detail of just educating them and saying, you know, I need to stand here because you are at risk for a fall, and let me just stand here, you know. We also have some special gowns that have a pattern of falling leaves on them, and it's a universal sign for our patients, so that for our staff, I'm sorry, so that when they do see them walking or up and around, that they understand that, oh, this patient's a high risk. It's just a quick alert for them. We also have some systems in place that hook into our chair and bed check pad system, which connects into a voice command recording. It's a recognizable voice so that the family, a significant other, a staff person, or anyone like that, that knows the person and that person will recognize that voice just telling them, please will you sit down, someone will be able to come and help you. If it's a mother, a sister, brother, anything like that, they can personalize it to put the person's name in there and just really help them to decrease the risk of falls.
Lisa, please sit down.
Yes,
right?
absolutely.
Any other interventions we should know?
We do have some other interventions. We have a geropsych unit, 28 bed, and the risk is there for those patients because they do wander. They're very curious. They like to go see what's going on, check things out. So we've increased the activities that we have on our unit, making sure that there's therapies available, that there's supervision and direction for those patients, and that they're not just wandering or looking and the risk of falls being very high. So that's something that has really helped our population in a lot of ways. Helmets, and some of you may already use the helmets. We've been using those for about 2 years now. And, you know, it does kind of provide a stigma for a patient with the helmet on, but at the same time, it provides a lot of safety, a cushion for that patient if they're a high fall risk. We have allowed them to decorate the helmets, and they really enjoy that.
The helmets.
Yes, and we help them too if they need some help with that.
And you have the staff put the helmets on too,
yes,
right?
We do have the staff put the helmets on just so that they know what they feel like and what the patient may be feeling at that time. But it helps to personalize it and provide some control for the patient too.
That's a great idea. How did you use the RAN tools?
We actually received some scripting information from the RAN tools and actually used that to help our family members become more involved. And especially when they're sitting at the bedside, it was just a great time to go and say, we're aware that your family member is at risk for falls. While they have been here, are there anything you can see that we could do differently or help to prevent falls? We also ask them, if someone began to fall, would you know what to do? And that's been very important, and we've gained a lot of information from that.
And I really want to emphasize that, because just by using that question with family member, if your family member falls, do you know what to do, really opens up a whole new conversation. Sally, tell us what happens at Reid when a fall happens.
We broadcast for the fall response team just as you would broadcast for a Code Blue team. And that brings the house supervisor, it brings the unit director, and then it involves the staff members who were actually caring for the patient. Again, we complete the post-fall huddle. One reason is to make sure that we get good data so that we can look at trends, where do we need to concentrate our efforts. But again, the most important thing with that post-fall huddle is to discuss what are we going to do differently now to prevent that patient from falling again.
And we'll see a little bit more about that in a video segment in just a moment. But Lisa, you talked a little bit about the human factors, the hidden aspects that were uncovered in your improvement process. You hold a meeting a week after the fall, after this fall team intervenes a week later. Why a week later?
It actually helps to just help people to feel a little more comfortable about what happened, or give them some time from the intensity of the fall actually occurring. They can think about improvements that they can make and those kind of things. Again, most importantly, it takes away that intensity that exists immediately after fall. You know, nurses and staff are worrying about, was the patient hurt? Is there something else I needed to do? Have the results come back from a test? And a week later, we have that information, so we're really able to talk about it. There's open dialogue about the fall, and it does reduce the fear and the anxiety. I do want to add, though, if we're seeing the same thing that's happening, and I'm sure that you have all been in the same position with this, you know, a fall's occurring the same time, the same staff are involved, you know, we've educated about what processes we need to have in place, but we still continue to see the falls, then we're going to pull our just culture process into that and be coaching, or sometimes we have to move to corrective action. So it depends on what's happening, and, you know, we have to individualize that. With these groups, the unit directors facilitate the group. I mean, who better to have in place than the unit directors to take over what needs to happen and own that process. It's not that they do everything, though, because I would say in observing these groups, the staff get very involved in what's happening and review what happened and improve processes, too. So, again, it's a team effort and something that we're very proud of. To kind of tie that up and complete the circle, the unit director then takes that information and places it in an SBAR, looking at the situation, the background, the activity or the actions, and recommendations, and sends that back out to all of their staff then, letting them know that a fall occurred and any recommendations or actions that were, you know, present during that time. Taking it a step further, then monthly, our CNO asks about our falls, wants to know what our stats are, any new equipment or anything like that, and we communicate that during the nursing directors meeting monthly.
So it's really, really apparent that from the CEO to the CNO to the unit directors to the front line, everyone's involved. Is that correct?
Yes, absolutely.
Any results yet?
Actually, in comparison, and these are, you know, just for this year and something that definitely we want to sustain, there's no doubt about that, but comparing first quarter to second quarter, 2012, we've seen a 57% decrease in our falls, which is wonderful, absolutely wonderful.
Tremendous work. Congratulations, and thanks for sharing with us some of the strategies that you've used. Sally and Lisa are part of a larger team at Reid Hospital and Healthcare Services focused on reducing falls. We had the opportunity to visit with him and get their perspectives as well. Take a look.
If we announced that somebody fell, I think everybody's back hairs would go immediately up and they would go into action. There is a real sensitivity to falls. So the teams are there in place to address falls and to debrief on falls.
I think that we just decided it was time to take some different approaches, and certainly by doing this partnership and going through the different strategies, I think it's energized the organization and the nursing staff, and it's allowed them to be able to take more ownership, because I think that that's probably the really key to the success. I think the biggest process that probably has garnered more staff input has been the weekly meetings and the debriefing sessions associated with the falls.
They came up with a fall huddle process where we analyze actually what happened in each particular fall and really get to the nuts and bolts, and we go right down to the staff level and ask them, you know, what could have made a difference in this situation.
What initially happens is we set off the fall response team. We do that on a voice-activated device. The health supervisor and the other people on the fall response team respond to that. That's when we use the post-fall huddle form. We fill all of that out. The nurses included, the charge nurses included, the health supervisor and the people on the team. And then a week after the incident, that's when we reconvene, and that's when we do the brainstorming session with the staff to see how we can prevent falls from happening in the future. And through some of the responses that I've been involved with, we've learned more about equipment that we weren't utilizing to the utmost, like the safety release belts, things like that have prevented falls from happening and helped our numbers go down.
One of the things that we use here is this post-fall huddle form. And so it's asking you basically to go down the checklist, and were all those patient safety things in this situation in place? Was the call light within reach? Did they have the special gown on? Were the signs on the door? Was the lighting okay? Was there clear passage to the bathroom? Had they been toileted frequently? All the things that we know contribute to falls. So with each specific case then, we go down this list and we check to make sure each one of those things were done and which ones weren't done, and maybe why they weren't done. This little card was another thing that Lisa gave us as a tool, again, part of that assessment piece that I think was really critical. And to get the unit directors involved, she gave each one of these this little card, and we basically went like a fly on the wall to someone else's department. And so we basically showed up and we just kind of walked down the floor and we said, how long did it take them to answer that call light when it went off? Or how long did it answer the chair alarm? Or did they have the fall risk magnet on the door? Just little things.
As a staff nurse just coming into the director role, you feel like you're privileged to offer your information, and there's not going to be punitive reprimands. You feel welcome to offer ideas to keep this from happening in the future.
You need to have a wide variety of people involved, bringing different perspectives to the table. Because initially, where you might think that it is a nursing issue because they're on the floor with the patient all day, there's other disciplines that you can come in and bring to the table, such as rehab services. You can bring your patient care technician or aides to the table to talk about what's going on.
So we're continuing to see from the goals we set on falls per thousand that we're coming in below where we felt was reasonable to target. Obviously, 0 is the ultimate goal, but we are coming in lower, and that gives us confidence and some hope that some of these process changes are in fact creating a difference.
Now we want to get you involved in this conversation. What challenges are you having, or what questions do you have for us? There are 3 ways to join us. Use the internet on the webcast page, select Ask a Question, type the question, and click Submit. Send us an email at vhatvlive@vha.com or call us at 800-565-8107, and be sure to press *1 to join the conference. We'd love to hear from you. Now, let's get to a few questions we've already received, and you're doing a great job with webmail because my iPad is filled. How do you involve pharmacy in your process? Who wants to start with that?
I'll start with that question. Lily, we generate a consult to the pharmacy in the form of a communication order. In addition to that, though, we have an electronic medical administration record whereby when the medication is listed on that record, and if it were to contribute to potential fall, there is actually a fall alert that is associated with that medication that prints right on the EMR.
Anything at Reid you want to highlight about the pharmacy as a member of your multidisciplinary team?
Absolutely. Stephanie Meeker from the pharmacy is our representative, and actually she has been working on looking at high-risk meds specific to certain areas, such as for geropsych, the medical floors, that kind of stuff, and just really helping the staff on the floor.
That's great. Do you assess fall risk or risk for injury in the emergency department?
We do not.
No? Do you assess fall risk in any other outpatient ambulatory care departments? Are you working on that, moving there?
We're moving there, but we have not established a tool at this time.
And it sounds like you're learning a lot on the inpatient setting that could be used in others. Doug, I think this is for you. Can Excela share more about your tool, how it was developed, where you obtained it? Is it evidence-based? Is it tested? Often quality staff and leaders will ask about the tested validity of a tool being used. We may want to reword this and to able to address the the aspects about evidence and validity and all that type of thing. So where did that come from?
Well, the tool was actually taken from an article published in the Journal of Nursing Administration.
The journal article you talked about initially.
That's correct.
Great, okay.
And the author of the study was from the University of Pittsburgh. The tool was not tested for reliability or validity. That's still in process. But we extracted that tool and then we modified it according to the patient population that we treated, as did the university when they took a similar model from the VA hospital.
So it sounds like it's in widespread use. We get this on every program. What's the nurse-patient ratio on your units where you're trying to reduce falls?
Nurse-patient ratio for us varies by the unit and the specialty that we have in acuity.
So give us an idea, general med surg.
5 to 1.
5 to 1. How about
Ours
Reid?
would be the same.
Same thing? Can you describe the floor mat and how they're used? So this question came in during the Excela piece, so I'm thinking it's a question for you.
Yes, I can describe the floor mat. It folds in threes, and it has a handle on one end of it, and therefore you can put a hook on the back of your door and hang it there, or on a wall, but preferably on the door so it's out of the way. It doesn't look so unsightly.
So is this used with your level 1, or when do you use it? How do you use it?
We use it at level 2.
At level 2?
Correct.
This is a great question. For Excela, I know you had a decrease in fall injury, but did you have a decrease in overall fall rates?
We have had a decrease in the overall fall rate. Unfortunately, I don't have the statistic in front of me, so I don't want to misquote the study. But
you're seeing both drop.
Both are dropping, and that was also an unexpected finding in the University of Pittsburgh study.
And for Reid, you're seeing fall rate drop. What about your falls with injury rate?
It is dropping as well.
It's dropping as well. Yes. So all of these tactics and strategies are working with both. We appreciate that the reason for implementation of this new type of program was because of the fall rates that you were seeing. Can you give us an idea of your fall rates per 1,000 patient days and injury rates per 1,000 days before and after implementation? You might not be able to answer that now. We may have to email the response back. It's just not a data point you have on the tip of your tongue.
I actually do. For the healthcare system, we were at 4.0 prior to implementation, and we're currently at 2.9.
Ah, great.
That's the overall fall rate. Our overall injury rate was at 0.2. It is currently at 0.1.
And when you're down at those small numbers, it's harder and harder to show the impact, but it's going in the right direction. Have you explored timed toileting with fall risk patients? I'm not so sure I know what timed toileting is. You might want to call us and clarify that.
Lily, this is, if I'm understanding the question correctly, it's a concept that we are talking about when I think about time toileting, it is establishing a toileting schedule. And rather than approaching the patient with, do you need to go to the bathroom? It's, okay, it's been 3 hours since you last went, let's get you up. So what you're trying to do is proactively engage the patient, and so that they don't have to wait for someone to respond to a call light, or they think, I'll just get up on my own.
Great answer. Excela, you know, I know we whiz by the interventions, the levels, but the audience wants to know more. What variables differentiate level 1 from level 2 for fall injury?
Well, we actually approach each patient with 3 questions. If they answer yes to 1 question, they're at level 1. If they answer yes to 2 questions, they're at level 2.
That's simple enough.
Simple enough.
That sounds great. How do you deal with patients who intentionally fall? So do you have patients that intentionally fall?
Yes, probably most
the direct
often
diverters
on Lisa's unit.
And talk more about that.
Yes. It does occur, and it's you know, one of those things that you can't always predict, that's for sure, but it is an assessment that we look on upon admission to see what kind of behaviors is this person showing, and what, you know, is there some attention-seeking things that are happening, or substance abuse issues that are happening, and, you know, just kind of get the focus of where things are at. We definitely try to pull in the family as much as possible to help us and give us a history about the patient too. So I would say it's truly about looking at an assessment, you know, and where that patient's at and what's going on. Again, it's an unpredictable behavior, but it is happening, definitely.
But Sally, no matter what, we still have to include those numbers in our fall rates.
Absolutely.
Intentionally falling or not. Are either one of you magnet designated?
We are not.
No?
We are not.
Do either of you report your data to NDNQI, because they require reporting of the total number of falls, not just simply falls with injury?
We do.
We do.
You do?
We do.
And so you report both?
Total.
Okay, so one of our guests does report to NDNQI, so if you have a follow-up question, please let us know. Do you do anything specific for patients that are falls risk that will be taking a shower to prevent a fall, either getting in or out of the shower? Do you do anything specific for patients that are at falls risk taking a shower, getting in or out of the shower?
I can actually speak to that.
Please.
We have a rehab unit, and we always make sure that we have an attendee in the shower or outside the shower curtain with that patient. Always. It's almost a mandate. If you want to get a shower, you're going to have to be attended in some way, shape, or form.
And I'll tell you, in new facilities and making rounds, having the privilege of making rounds in our hospitals constantly, I'm seeing more and more getting rid of any of the stoops or making everything as level as we can. Reid has added activities to keep behavioral health patients busy. Have either of you implemented any kind of falls busy kit for med-surg patients, things to keep med-surg patients busy?
We have not.
No?
It's actually a good idea.
We do get consulted a lot, I will say that, for patients that are high risk, and we do give them interventions that they can utilize. So we work as much as possible, but we haven't proactively put anything on the units to help them with that.
That's a great idea. For both of you, and it's clear you study your data well, what do you find as the leading reason for falls?
I would be able to answer that. It's generally activity before or after toileting.
Before or after toileting?
We would
Reid
concur.
say?
Yeah, absolutely.
So we really should pay a laser beam attention to that. Are either of you a safety net hospital?
We are.
You are?
Yes.
Okay, so Axela Health is. The next question, and keep them coming, you're doing a great job. What are the 3 questions again for injury assessment? I think that's back to Excela, right?
It is. I would recommend that they look on the website where we're posting the tool, just so I don't get it wrong.
So on page 9 of your handout, you'll notice hyperlinks to the resources at Axela Health and the resources at Reid, and you can click on those and get more of these actual forms and resources. And as always, you can email us at VHATV, and we'll make sure that we get your question answered if we didn't get it answered the first time. I'm interested in hearing more on what pharmacist actions are being taken after they receive information that a patient is at falls risk. Do they have any medication review process that leads to contacting the physician for alterations to the medication list to reduce falls, et cetera, et cetera?
That would be a yes, because on the electronic MAR, we get that prompt that the medication will potentially lead to a fall because of its sedation effect. And from that point, then there's discussion between the pharmacist and the physician. Sometimes no alteration is made because we have to balance risk versus benefit.
Right.
But sometimes we actually make a change in the treatment plan.
Right, great answer. We should have anticipated this. What fall risk assessment tools do you use? Do you use Johns Hopkins? Do you use Morse? What do you use at Reid?
We have our own.
Homegrown?
But we are looking at other options. We're evaluating that right now. So.
And we don't measure fall risk because
that's right.
we presume that all patients are at risk for fall.
That's right, because you assume all patients are at fall risk. A follow-up to the shower question, I was referring to interventions other than with staff members. Have either of you tried non-slip shower shoes or spraying something on the shower floor to prevent slipping like a coating?
We have not. We've talked about those cases, and we have had some problems where, you know, sometimes the soap or the shampoo may be building up on the bottom of the shower floor, so we've looked at different options of what are we cleaning it with? Are we making sure that it's kind of a gritty surface so that there isn't that problem? So we are looking at the shoes and looking at different options for that.
Speaking of the gritty surface, we had just remodeled some within our organization, and when the floor people laid the floor, they actually put a grit kind of paint or covering on the floor, so when you actually walk in, you can feel almost like a sand on the floor.
A tile. It's a permanent tile that has the grit on there.
That's a great conversation. Really sorry we can't continue with the questions, and we'll get back to every one of you that we didn't answer today. And as you know, we've covered a lot. So I'd like to ask each of you, single most important thing quickly here that we want everyone to remember about all of our conversation. Lisa, I'll start with you.
Sure. Don't let your guard down. Patients' conditions change throughout their stay, and we have to be alert to those changes at all times, and it takes every one of us.
Sally, from your perspective.
I think until someone develops that silver bullet that will be the end-all to falls, it's going to be something that we're going to be watching and looking at for a long period of time. And consequently, I think it's good every now and then to reevaluate who are the members of your team and bring in some new blood, someone with a different focus, some fresh ideas.
Katie?
Staff buy-in. Staff involvement is very, very much necessary, and the only way for a successful program is if you get them involved.
And Doug, you have the last word.
Well, also consider leveraging technology to assist providers in keeping patients safe.
Let's review our learning objectives and the key points that we've made in today's program. The first objective, describe the hidden issues that exist in the hospital setting which contribute to falls. We've talked about leadership issues and things like the unit manager and charge nurse being aware that a fall occurred on their unit and that leadership involvement is essential at all levels. We talked about supply and equipment issues, accessibility of safety equipment, and how to order and store safety equipment to make sure that there's equipment for every patient in every room. Cultural issues we talked about, you know, getting rid of that traditional nursing inevitability mindset that no matter what, falls are going to happen. Got to get over that. And we need to acknowledge that spreading leading practices to other units or other facilities in a system is hard work. We've talked about addressing the fear and anxiety that occurs in the staff after a fall and the importance of building a culture of non-punitive open disclosure where all staff are accountable. Some of you know it as just culture. Our second objective was to discuss strategies to reduce falls and decrease patient injuries from falls. We've talked about the use of a nursing bundle, using a fall injury assessment rather than a fall risk assessment. We had a fun conversation about the use of helmets and staff experiencing them before the patients do. We've talked about implementation of the post-fall huddle, and we talked about technology and hardware that will help you, like evaluating the use of low beds and fall mats. And we talked about the voice command. So thanks to everyone for being here. We've had a great time and a lot of information we've been able to share. And thanks to the teams at Axela Health and Reid Hospital and Healthcare Services for allowing us to interview them and get a first-hand look at all their fall reduction programs. Most of all, thank you for taking time out of your busy schedules to join us. We know this is a really important time for you, for us, and for our patients. For more information about VHA's work to support Partnership for Patients, please visit vha.com/PFP. And remember, our next program will be Thursday, September 13th from 12:30 to 1:30 p.m. Eastern. We'll update you soon with the details, so look for your email. Remember, we're always here for you. From VHA TV, I'm Lily Jelinas. Thank you for watching.